Hello, welcoming you for the INICET May 2022 recall questions. So these are all the questions obtained from first-hand information from the kids like you. So sometimes the choices may be differ or question may be little bit differ. So if any changes are there, drastic changes, let us know, we will correct it because it's totally based on the information given by your people. So I'll start with the first question. Choose the correct pathogen based on the cell wall shown in the image. They say the one image is there. In this image, the important thing is ergosterol, chitin, mannan. Chitin, mannan and ergosterol. These are all the component of fungus because the chitin and mannan, glucomannan are cell wall, fungal cell wall, and ergosterol is the component of fungal cell membrane. So this is sufficient to tell it is fungus. But furthermore, beta 1,3 beta glucan, 1,3 beta D glucan, it is very specific for some fungus. There is an assay called 1,3 beta D glucan assay. Some assay mainly for, remember the mnemonic CAP, to diagnose CAP. This is a regular question, many times the question they asked. Candida, Aspergillus and Pneumocystis. CAP is the mnemonic. And another thing, the same thing is absent. Absent in, remember, CM, Cryptococcus and Mucor. Cryptococcus and mucormycosis. Zygomycetes, those people, it is absent. But anyway, only with the help of this you can identify some fungus. With this knowledge you go to the choices. Mycobacterium tuberculosis is a bacteria. Mycoplasma pneumonia, there is no cell wall. Rhinosporidium seaberry, once upon a time it was fungus. Okay, now it is protozoa and it 100% matches with Aspergillus. I don't know, they gave Aspergillus fumigatus or some other choice, whatever it may be. If it is Aspergillus, that is the correct option. We'll go to the next question. Yeah, always one question from biomedical waste management is there. Here also, it's a chemical management. Choose the correct management of mercury spill from the sphygmomanometer. So please remember, wherever there is a spill of mercury, you need to do some do's and don'ts. Number one, what you need to do is open all the doors and windows and switch off the electricals. And fans, because it will allow the mercury to spread and it's easily become vaporized. And very, very important, wear PPE, personal protective equipments, goggles, gloves, everything. And very important, you need to collect the mercury beads by two-way. Should not take your hands because it makes more beads. Number one, you should use cardboard or thick paper. You can take it, okay, or you can collect with syringe. Remove the needle and slowly you can collect the mercury drops into the syringe. And finally, you should not put it in any dustbin or anywhere. You need to put it in water, a translucent container or any white container which contains water, the container should not be made up of any metal because it may react. It should be either plastic or any porcelain. And you need to write a label called it's mercury waste. This is the method of disposal of mercury. What you should not do not broom, do not take it with your hands, or do not use vacuum cleaners. This you should not. Okay, and in this room you need to write vacuum mercury spill happened, so you not allow the people to enter inside. You restrict the entry, and you should do, and you need to document everything. Okay, now we will see the steps. See, mercury spill. Never touch mercury with bare hands. Wear all protective gears. Gather mercury using stiff paper and suck into an eyedropper syringe without the needle. Put it in the container containing water. Scotch tape around the bottle. Keep syringe for further use. Got it? So based on this, come to the answer. Collect by using cardboard and put water. Yes, it's a correct option. Suppose collect by using your hand. No, you should not use. You should not put it in environment. And you should not broom it. And you should not use dustbin for it. A very easy question. Very practical question. Next is which of the following need not be screened before transfusion? As per Indian government guidelines, NACO guidelines, the following tests are mandated before transfusion. Or these are all the mandated screening tests for blood transfusion. One is HIV, another one is hepatitis B and hepatitis C. Next is syphilis. Next is malaria. These are all mandated. These 5 tests are mandated. See the list here. The blood screening test, HIV, hepatitis B and C, syphilis and malaria. So here the option is dengue. Because dengue never spread by blood transfusion. It's by Aedes mosquito. So these are all the bloodborne pathogens. You may ask a question, sir, what about leishmania? What about toxoplasma? These are all bloodborne pathogens. If the facility available, we can do. Many other abroad, many other Western countries, there are 25 tests are there, panel is there. Toxoplasma, histoplasma, leishmania, many are available. Babesia, many other bloodborne pathogens also available. But in India, mandated tests are these 5 tests: HIV, hepatitis B and C viruses, syphilis, MPMF. Okay, so here the answer is dengue. Next is biopsy from a warty lesions of foot shown in the image. Choose the diagnostic form based on the image. So where there is a cauliflower or warty lesions, and see the image, you can get brown color, round shape. Brown color, round shape. So clinically, we can diagnose this as chromoblastomycosis. Chromoblastomycosis is a clinical condition. It's a wart or cauliflower-like lesion. Subcutaneous mycosis caused by many people. Cladospora, Phallophora, Acrimonium, Panacea, many people. But the diagnostic form is very, very important. We call it as copper penny bodies. Other name for copper penny bodies are sclerotic bodies. Other name, medullary bodies or muriform bodies. All are same, all are diagnostic form of chromoblastomycosis. See here, the option budding yeast, you can see it in Cryptococcus. Asteroid bodies, diagnostic of sporotrichosis. Negri bodies, rabies. So it is sclerotic body. What are the other names? Copper penny, medullary or muriform bodies, diagnostic of chromoblastomycosis. It is a subcutaneous fungal infection. Next is what is not a AIDS defining malignancy? There are important 3 AIDS defining malignancies are available. Number 1, Kaposi sarcoma. It is caused by, associated with human herpes virus 8, otherwise called Kaposi sarcoma virus. Another one is invasive cervical cancer, usually human papilloma virus 16, 18, 31, 33, these people associated. And third one is non-Hodgkin's lymphoma. Many agents are causing, and if you see virology, human herpes virus 4, otherwise called Epstein-Barr virus. It's one among the agent. So non-Hodgkin's lymphoma, invasive cervical cancer, Kaposi sarcoma. These people are AIDS defining malignancies, not malignant melanoma. It is not an AIDS defining malignancy. Next is it's a tricky question. If you know the terminology, you can answer. Which is a molecule? What is molecule? Molecule is nothing but bacteria without cell wall. A group of bacteria devoid of cell wall or without cell wall. Bacteria without cell wall. We otherwise call it as L form. L form means Lister Institute form. We have 2 types. One is called stable natural L form. Because they are devoid of cell wall. Permanently there is no cell wall. Naturally without cell wall. Classical example, you are aware of that, mycoplasma, ureaplasma. These people, we call them a stable L form. Apart from that, we have available other type of L forms. Okay, other type of L form. A period of time they will become L form. They have the cell wall. In the presence of some agent, they will lose the cell wall. If gram positive, if they lost the cell wall, we call them as protoplast. If gram negative, they lost the cell wall, we call it as spiroplast. Protoplast and spiroplast. See carefully here. Chlamydophila pneumoniae is obligate intracellular. Chlamydia trachomatis, obligate intracellular. Orientia susugumushi, they have cell wall. Orientia susugumushi, which is causing scrub typhus. Mite is the vector. They have cell wall. They all possess cell wall except ureaplasma. So ureaplasma comes under the group called molecule. It comes under the group called molecule. So where there is an absence of peptidoglycan cell wall, which is present in all other bacteria except a group of bacteria, we call it as molecule. Moly means soft, cute means skin. So without cell wall, they are looking very soft. Next is choose the acid for staining organisms. So we must know what are the list of acid for organisms. Here is the list. You can make it all kind of mycobacterium. That's the number one example. Mycobacterium tuberculosis, Mycobacterium leprae, atypical mycobacterium, atypical mycobacterium, apart from that, nocardia, rhodococcus, Legionella macdadii, then Tinea saginata egg, coccidian parasites, which includes Cryptosporidium, Cystisospora, Cyclospora. Coccidian parasites, Candida albicans, bacterial endospores, all these people are acid-fast structures. So if you remember this, easily you can make it. In this list, they put organisms, I think multiple choices question. Some people gave Cryptosporidium, some people gave Cystisospora, whatever it may be. Both are comes under coccidian parasite. Yes. Nocardia is acid fast, Mycobacterium leprae is acid fast, except actinomycetes. Nocardia and actinomycetes both are gram positive filamentous bacteria, but the important difference, Nocardia is partially acid fast, where actinomycetes is non-acid fast. That's all. Next is choose the correct pathogen based on the life cycle shown in the image. People give the name, but we didn't get exact life cycle. I hope so. But this is almost similar. Yeah, man excretes Rhabditiform larva in the stool. Rhabditiform larva in the stool. These Rhabditiform larvae develop into filariform larvae that penetrate the skin, where Rhabditiform larva is the diagnostic stage. Rhabditiform larva is the diagnostic stage. And filariform larva is the infective stage. And the mode of transmission, skin penetration. This first clue. The skin penetration only few people. Ankylostoma, Necator, Strongyloides and Schistosoma. Schistosoma you need to have Cercariae. It is not Schistosoma. Coming to this side, it also causes autoinfection. Another important clue. It also causes autoinfection. So it also causes hyperinfection syndrome. And it directly lay the egg immediately become larva. So man excrete only the larva. It is ovoviviparous. Yes, now you come to conclusion easily. It is nothing but Strongyloides stercoralis. Because Ascaris mode of transmission, Enterobacter vermicularis mode of transmission, ingestion. Ankylostoma is a tough competition, but ankylostoma it won't cause autoinfection, and ankylostoma diagnostic stage is egg. The hookworm diagnostic stage is egg. Diagnostic stage is egg. Okay. So here, based on the life cycle, the answer goes to Strongyloides stercoralis. It causes larva occurrence. And the treatment is usually ivermectin. Ivermectin is the treatment. Next is based on the image, choose the correct statement regarding the pathogen. So see the image. This image gives an idea. Hexacanth egg and some filamentous structure. Many times the same egg they shown in the exam. 2 to 3 times the same image came. Hexacanth egg is a cystode and the filamentous structures suggestive of Hymenopsis nana. Hymenopsis nana. It is otherwise called dwarf tapeworm. Dwarf tapeworm. Make it very simple life cycle. Human is the definitive host. Human excrete egg in the stool. Another person take the egg. There is no intermediate host. And drug of choice is praziquantel. And drug of choice is praziquantel. No intermediate host for humans. It also causes autoinfection. Usually it is asymptomatic. Rarely it causes intestinal symptoms. Abdomen pain, cramp, diarrhea, those kind of things. See here. Albendazole is treatment, no. Albendazole mainly for nematodes. Intestinal nematodes like Ascaris ankylostoma, and in cystode also we are using, especially neurocysticercosis. Albendazole is the treatment. Leaf shape parasite. There are two people are there. If you go to protozoa, leaf shape is Giardia. Or many of the trematodes. Trematodes also almost leaf shape. Eating water plant is the source of infection. Aquatic plant is Phaeolopsis busci or Phaeola hepatica. Phaeolopsis busci, Phaeola hepatica. These two people aquatic plant or the second intermediate host. And here the appropriate option is most infections are asymptomatic. Most infections are asymptomatic. Next is choose the wrong option. Chemoprophylaxis. Yes, for that you should know in which CD4 count what are all the common opportunistic infections available. And there is a government guideline is there where less than 50 you can go for cytomegalovirus. Less than 100 you can go for cryptococcus, toxoplasma, those kind of people. Less than 200 pneumocystis, those kind of people. And the wrong answer is pneumocystis mandated if CD count is more than 350. No, if the CD4 count is more than 350, 99% there is no need of any chemoprophylaxis. Usually, where it is less than 200, you need to have a lot of chemoprophylaxis because that is a right CD4 count, many opportunistic infections will enter. See here, this chart will help you. Yeah. Around 250, they can get oral candidiasis, varicella, kaposarcoma. When it comes to 200, pneumocystis. So because of that, when the CD4 is less than 200, you need to give pneumocystis. Zoonosis pneumonia, especially the cotrimoxazole is the prophylaxis. Cotrimoxazole is a prophylactic for many diseases. Toxoplasma, it's a chemoprophylactic agent. Coccidin parasites like Cystisospora belli, Cyclospora, it is the treatment and chemoprophylactic. Many bacterial infections, Nocardia, pneumocystis. So 5 major opportunistic infection, one drug, cotrimoxazole is the prophylactic agent. Okay, when it is around 100, you can go for cryptococcus. When it is around 50, go for cytomegalovirus infection. If we know this chart, it will be very easy. If we know at what CD4 count which opportunistic infection occurs, based on that you can tailor-made chemoprophylactic agents you can make it for to prevent the opportunistic infection. Next is which is used as a disinfecting agent but not sanitation. Confusing. For that, you follow my notes, the definition is that. What is disinfecting agent? The agent which inhibit the multiplication of the pathogen in inanimate media. What is sanitation? Agent which reduce the microbial load. Agent which reduce the microbial load. 10,000 become 7,000, 6,000, that is sanitation. Got it? Among this agent, if we go for bleaching powder in high concentration, it acts as a disinfectant. In low concentration, it acts as a sanitizing agent. Household bleach, we call it as calcium or sodium hypochlorite. In different concentration. In low concentration, it acts as sanitizing agent. So it comes under both category. We can't say disinfecting and not sanitation. Penicillin is an antibiotic. We cannot call it as a disinfecting agent or sanitizing agent. Methylparaben is a cosmetic. It is a sanitizing agent. It may little bit reduce. It is available in cosmetics to reduce the bacterial load, not full. So, very powerful plasma sterilization we are using hydrogen peroxide. Hydrogen peroxide it causes DNA damage. Plasma sterilization. Is based on hydrogen peroxide, one of the powerful disinfection method. It is not a sanitizer. It massively destroy the pathogens, massively destroy. So among the 4 choices, hydrogen peroxide is a perfect disinfecting agent. We can't call it as a sanitizing agent. Got it? Right. Next is, which virus, this already we have discussed in the CBT. Which virus undergo genetic reassortment as influenza virus? So genetic reassortment usually seen in viruses with segmented RNA. Any virus with segmented RNA, they easily undergo genetic reassortment. So what are all the segmented RNA viruses? You remember mnemonic ARBO, but I always tell write in alphabetical order. The mnemonic is ARBO, write in alphabetical order. Arenavirus, Bunniaviridae, Orthomyxo, and Rotaviriovidae. Arena, there are 2 segments are there. Bunnia 3, Orthomyxo 8, Rotaviriovirus 10 to 11 segments. This is the mnemonic. So among the virus which is having segmented RNA, those virus will undergo genetic reassortment like influenza virus. Here 4 pictures are there. Coming to the D picture, bullet shape virus with G protein is rabies virus. It is not a segmented RNA. This is antenna shape, satellite shape. So it is adenovirus. It is a DNA virus. And this is filamentous. Ebola virus. Filamentous or Ebola virus. Here you can see double stranded RNA virus. Double stranded RNA virus and segmented RNA is rotavirus. Rotavirus. So it is the option. So this image is the rotavirus is the option. Rotavirus undergo, same question we asked in the CBT. Like influenza virus, which of the following virus exhibits genetic reassortment? Is rotavirus. Next is, which is wrongly matched primary and secondary immune response. So make it the table very easy. Primary immune response, secondary immune response. Follow mnemonic. Primary is IgM mediated, secondary IgG mediated. Primary is slow, sluggish, short-lived. This is prompt, powerful, and prolonged. Apart from this, very specific is secondary because IgG. The binding capacity, affinity is more in secondary IgG. So we call it as affinity maturation. When IgM, it will hold like this, IgG hold like this. Affinity maturation based on this point, and it is immediate. It has some lag period. Primary is having lag period. It is immediate because of memory. Because of memory. Okay, these are all the difference between primary and secondary. And secondary, primary, that is mainly used for vaccination. Vaccine gives primary immune response. Memory it creates. When the original pathogen comes, secondary. So, see here, primary IgM, secondary IgG, right statement. Here it take 4 to 7 days, here 1 to 2 days, yes. It is short-lived, it is prolonged, yes. And important is, primary immune response antibody affinity is low, secondary is high. So that is the wrong statement. That is the wrong statement mentioned here. Okay, very simple. If you understand the primary and secondary immune response differences, it will be very easy. Next is antigen binding to MHC1 activates. This is a very simple direct question. I hope they already discussed in pathology also, because some questions are overlapping in many subjects. It's a direct question. MHC1 present in all nucleated cells. And MHC1 always interacts with T cell receptor of CD8. And is usually involved in transplant, rejection reactions, many things. If you come to here, MHC2, it present in professional antigen presenting cells, and it always interacts with T cell receptor of CD4. See here, 1 interacts with CD8, 2 interacts with CD4. Easy to remember. This is a mnemonic we used to teach in the class. There is no cross presentation. That is called MHC restriction. There is no cross presentation. We call it as MHC restriction. So here's a very direct question. Antigen binding to MHC1 activates cytotoxic T cell. Once the cytotoxic T cell got activated, it releases perforins, granzymes, many other agents. They make pores into the cell, they kill the cell. Because of them, we call it as cytotoxic T cell. Next is which of the following need airborne contact preventing isolation in hospital? For that, you need to know different type of isolation procedure. Droplet isolation, airborne isolation, contact isolation, like that. If we know the pathogens which comes under droplet, which comes under airborne, it will be easy. It's a little tricky question. Many times we confuse droplet with airborne. That's a problem. See here. This is contact precautions. MRSA, ESBL, adenovirus, diarrhea, big list, rotavirus, hepatitis A, all diarrhea causing people, scabies, chickenpox, herpes simplex, many are there. Next is droplet, pertussis, influenza, meningitis, causing people, pneumonia, coxsackie, mumps, diphtheria, many things. Airborne, only few easy to remember. Chickenpox, disseminated herpes, measles, tuberculosis, avian influenza. These people are airborne precautions, need to be isolated. Chickenpox, disseminated herpes, measles, tuberculosis, avian influenza. Only these people. Not only avian influenza, you can swine flu also we can add. Okay, based on this diagram, it's a very important diagram. So you must know what are the different type of precautions. Contact, droplet, airborne. if you know about the pathogen, you can answer. No need to mug up or no need to by God. If you know the pathogenesis, how the disease spreads, easily you can make it. If you know the mode of transmission of the pathogen, easily you can make it out. Not an issue. See here. In this, CJ disease is a slow viral disease, eating brain or those kind of things, or it's a genetic, it's a misfolding of proteins. Nipah is droplet, not airborne. Aseptic meningitis, droplet, both viral or bacterial etiology. Both either viral, bacterial usually 90% septic meningitis, pyogenic meningitis. So here the correct answer, we need airborne infection prevention isolation needed for measles. Here we mainly need it for measles. For that, the diagram is very important, and you need to know about each pathogen, how it spreads. Many times people confuse with Nipah and measles, both by inhalation, but one is airborne, another one is droplet. That difference you should know. Got it? Next is, a patient tested positive for RK39 antigen test. That's a clue. Nowadays the test is not in use, but still not very specific because they are using Mycobacterium species to diagnose leishmania. If this test is positive, it indicates visceral leishmaniasis. Which is caused by Leishmania donovani. The gold standard diagnosis, demonstration of eMedicoz. Demonstration of eMedicoz is the gold standard diagnosis. Visceral leishmaniasis. Got it? So once if you diagnose other type of leishmaniasis, you are all aware of that, cutaneous, which includes oriental sore or Delhi boil. Oriental sore. Another one is mucocutaneous. We call it as espundia. Chicrul ulcer, many are there. Okay, so now it's a case of visceral leishmaniasis. What is the treatment? Visceral leishmaniasis, the best treatment is liposomal preparation of amphotericin B, where miltefosine previously they used and sodium stibogluconate. These are also having anti-leishmanial property. We are using for mucosal or cutaneous leishmaniasis. We are using it for mucosal or cutaneous leishmaniasis. Fluconazole is an antifungal drug. We are mainly using for Candida, Cryptococcus, those kind of people. So liposomal amphotericin B, don't think it's only for antifungal. Its main property antifungal. It pour on the ergosterol. Apart from that, we are using many other diseases like visceral leishmaniasis and mainly free-living amoeba, Naegleria fowleri, Acanthamoeba. Drug of choice, promising effect. We got it from liposomal amphotericin B. So with this we complete all important 16 to 17 questions. 2-3 questions overlapping discussed by pathology as well as PSM. Any doubt or any controversies there, any options? Because again I'm telling, it is based on your feedback. The questions are given by you people. So if any choices are wrong or any other thing is there, we will change according to that. If any other option is the very best option, we can change. Whatever given is the best. Okay, still if you are able to give, recollect something strike your mind, any other option is there, sometimes it's subject to change also, we will update. Thank you.